Hi there, this is Rob Arntfield speaking to you, and today we'll talk about lung ultrasound for the COVID-19 patient. I am the medical director of the ICU where I work, which is the Critical Care Trauma Center in London, Ontario. I also direct the Critical Care Ultrasound program at the same center. Today's agenda will include a brief introduction to lung ultrasound. We'll talk about some acquisition pearls. We'll briefly review the classic lung ultrasound signatures, and then we'll follow up with the patterns seen in COVID-19 patients. We'll talk about some practical considerations about scanning these patients and then how to integrate these findings. By way of introduction, lung ultrasound is an artifact-based method of imaging. It is not like solid organ ultrasound at all, and if you are new to lung ultrasound, I would suggest that either after this tutorial or maybe prior to going any further, you review some of the resources on the screen here for a deeper dive into some of the fundamentals of lung ultrasound. With respect to scanning technique, I will outline my preferences and some of the options available. You will see a great amount of variety in the world and in the literature with respect to scanning technique. However, this is what we use at our center, and we do about 3,000 lung ultrasounds in the ICU each year. So you have a choice of transducers, of course, and everyone will have their favorite. We use the phased array transducer primarily, and this is for many reasons. Its small footprint and its versatility to be used to image other organ systems that are often in our interests at the time of scanning a critically ill patient. The curved linear array transducer for the lungs is popular with some because it has a larger footprint and therefore captures more of the lung tissue than the other transducers do. The linear array, of course, given its near field range, is excellent with near field resolution, however lacks the depth to image the pleural spaces. And other transducers, including the microconvex or the TE transducer for transesophageal lung ultrasound, are used by some as well. Now, as mentioned, the linear probe provides excellent resolution of the pleural line, which will become of interest in the COVID patient, but because of its limitations to image deeper into the chest and the pleural spaces, I would generally discourage you from using this for the COVID-19 patient. Now, scanning locations and where to scan is a quite varied topic across different experts. We use a 4-view protocol, as I'll talk about, but globally the philosophy to consider is that the intensity of sampling will obviously influence the amount of time that you spend at the bedside, and you have to ask the question of how nuanced the question is that you're asking. If you are looking for a cause of severe hypoxemic respiratory failure that is undifferentiated, a 16-view protocol does not really make as much sense as perhaps a 4 or 6-view protocol. So target the intensity of your scanning locations and the number of them to perhaps the gravity of the clinical presentation. So we can imagine, though, that accuracy does increase with the number of regions that you do image. Some people, rather than imaging in discrete locations, will do something akin to a lawnmower or called bicycling as they move the probe rapidly across the chest, scanning sort of continuously and gathering information. This does work in real time. It is harder to save those images if you're planning to save them and incorporating them either into the medical record or quality assurance program or education, but everyone has their preferences. The sweet spot, I think, for imaging locations is somewhere between 4 to 6 locations per hemithorax. So I'll show you these locations now. The anterior and mid locations, so corresponding to the upper lobe and middle lobe or lingula on the left side, are ideal locations to find representative pathology and images of A versus B line patterns. You then move into the pleural space views, which is typically in the mid or posterior axillary line. And this now gets into the diaphragm and imaging for the pleural space. This is where you need that depth that you do not have on a linear transducer. And if the patient is bedbound, you might get the fourth spot here, akin to what's called the PLAPS point from the original literature, where very dependent pathology can be found. And if the patient is either prone, which is quite common in COVID patients in the ICU, or ambulatory, able to sit up, then you can gather information from the posterior aspects of the lung as well, rounding out the 5th and 6th locations on the hemithorax to gather the information about what the dominant lung signatures are. Now, there's some basic scanning technique advice that I would offer that I think is useful even for those with some experience. And firstly, the preset to use. Now, this is again quite personal. However, I tend to prefer the abdominal preset over all other presets. Many vendors, including Sonosite, has the lung preset, which is exceptional at bringing out the A lines, B lines, and sliding patterns that we'll review shortly in the anterior regions. However, the lack of image enhancing features that is part of the lung preset that brings out those artifacts does make imaging in the pleural spaces slightly darker. And in my experience, imaging the pleural spaces is fraught with more difficulty for the novice or intermediate user. So I prefer the abdominal preset because it brings out the artifacts well and offers no disadvantage when I move to the pleural spaces. Avoid placing ribs in the middle of your image. The index mark should point towards the head, and you would avoid the ribs in the middle of your image, for it obscures the presence of meaningful pathology. One of the key things to bring out A lines versus B lines appropriately is to ensure that your probe is perpendicular to the pleura itself, which is a curved anatomic layer. And just because you feel you might be perpendicular to the chest wall or resting comfortably on the chest wall, it does not mean you're perpendicular to the pleura. So some gentle tilting side to side will typically bring out the A line or B line pattern a little bit more clearly as you're scanning. Increase your depth after you're done scanning the anterior regions and mid regions of the lung when you go down to the pleural space, in light of the fact that, of course, you're looking at possibly deeper structures, possibly imaging through the entire hemithorax if there is either consolidation or pleural effusion. And a well-aerated lung is most challenging to image, of course, at the bases. The presence of a pleural effusion or consolidation makes pleural ultrasonography much easier when imaging at the costophrenic regions. And so just bear that in mind, because as we'll talk about, COVID patients do not tend to have much in the way of pleural effusions. So a quick review of the classic lung ultrasound signatures that you will be greeted with whenever you put a probe on someone's chest. You'll either see A lines, B lines, consolidation, or pleural effusion. Now, of course, the other main artifact is lung sliding that you'll also see, which is essential for the exclusion of pneumothorax. But I've not emphasized that here because our main preoccupation in this patient population will in fact be the presence or absence of airspace disease. And of course, combinations may occur and should be expected to be seen. This includes pleural effusion with consolidated lung. In most cases, or in many cases, I should say, the consolidated lung in the context of a pleural effusion is compressive atelectasis and not necessarily pneumonia. And so that needs to be taken into consideration. You will see a partial consolidation, often sometimes called a shred sign, or subpleural consolidations with adjoining B lines. And occasionally you'll see an A line pattern that is briefly interrupted by some B lines that may be passing through during tidal ventilation. So here we see the example of classic pathologies. We see the A lines with their classic reverberation of the pleural line at the same distance as it is from the skin surface to the initial pleural line. And the number of A lines is not important, of course. Just if you have one, that becomes an A line pattern. For the B lines here, we see sliding lung, and we see that the vertical hyperechoic rays that emanate from the pleural line, they move with the pleural line, and very importantly, they descend to the bottom of the ultrasound screen. And in this case, you can in fact see that there's sort of, when the B lines aren't present, you do sort of get a bit of an A pattern, and it's important to acknowledge that the A lines can be present on the screen at the same time, and that you're going to go with the dominant profile is going to be the most pathological profile that you see. So just because you can see A lines here, the B lines trump the A lines. Pleural effusion, well captured here in the right costophrenic angle. You can see here the hypoechoic or anechoic region of pleural fluid, and you can see the compressed lung under the burden of that fluid causing a consolidation picture. To be distinguished, of course, from this example of consolidation Here, where we have no evidence of pleural effusion, the diaphragm is here, there's very trace amount of fluid, and the lung itself is densely consolidated, and also showing, in this case, dynamic air bronchograms flying into view, which is highly suggestive in this case of a mnemonic process. Regarding the pleural line, we do need to talk about this, especially if you're using a linear transducer ever, as there's many bright white lines. You must always center your attention to the ribs and the first hyperechoic line that is deep to the ribs. Its movement, of course, as we mentioned, excludes pneumothorax with 100% certainty at the site of your transducer. And this is the entire artifact of the pleural line is, of course, created by the interface of the visceral and parietal pleura rubbing against each other and creating this sort of sliding motion. Now, I want to draw your attention here to how smooth this pleural line is, and this will be, of course, in comparison to some of the images we're going to show shortly in the COVID patient. And speaking of findings in COVID patient, there is growing literature supporting the typical findings in these patients, and this has been published in Intensive Care Medicine as a letter recently, and we will use this as our official checklist to go through the expected findings, and this is, of course, what all of us are seeing on the front lines as well. So let's break these down. So a thickened pleural line is probably the most commonly described element that we're seeing in these patients with a B-line pattern, of course. So if you look at these two images, they're both B-line dominant patterns, as you can see, pleural sliding in both. But the difference here being that the pleural line on the screen right here, you can see has a tremendous amount of brightness to it and is highly irregular. It's not smooth. I sometimes imagine perhaps it's my Canadian roots coming out, but skating on the pleural line, and this would be very difficult to skate on. You'd stumble. This pleural line, in fact, needs a Zamboni, whereas this pleural line is extremely smooth, and in this case is more fitting of a hydrostatic etiology of the B lines, rather than this, where we tend to think of this degree of irregularity being due to infectious causes or inflammatory causes. Now, we mentioned the B lines, of course, and they can occur in different patterns, and it's not immediately clear to me that any single pattern of B lines is dominant in COVID over any of the other causes of B lines in patients. So here we have sort of a multifocal B line, sort of emanates as, looks like a single, but then it kind of breaks up into multiple B lines, as you can see. And again, this is that same image before. You can see that there's a sort of broad sort of spotlight, if you will, formed by a whole bunch of B lines that are coalescing together. These patterns are more typical, in my experience, in those with inflammatory or infectious causes of their B lines rather than the hydrostatic or pulmonary edema cause of B lines. I should mention that these are images from COVID positive patients. So with respect to consolidation, the two main forms of consolidation you'll probably see are the subpleural form and the translobar form. Now, the subpleural form are slightly more subtle, and they are really just further exaggerations of the irregularity of the pleural line. If you look at this pleural line here, it's a little bit thick, not as thick as the previous image, but you can see here there's an entire segment or wedge taken out of the pleural line as this area of lung has begun to consolidate, and it's neighbored or it's flanked on either side by some B lines. Here we see an example of a slightly undergained image of the translobar consolidation pattern, which is a bit more familiar to us if you've been doing lung ultrasound, either from the appearance of a fully consolidated lung under the burden of pleural fluid, or in this case, really with very minimal pleural fluid. This is, again, more typical of the pneumonia patient, where the loss of air in the lung isn't from it being compressed from pleural fluid, but more likely from its displacement from the contents of the alveoli and the lower airways because of either pus or secretions. Now, one of the observations which we have seen and is published is that pleural effusion is quite uncommon in these patients for reasons that cannot be fully explained, but it is important to note that you will, when you scan the costophrenic angle regions, here's the right side with the diaphragm and the liver, and the lung is screened left, that the most likely finding you will experience is going to be the curtain sign. And of course, reminding you that the curtain sign is the normal appearance of an aerated lung in these regions, such that when the patient engages in tidal ventilation, some element of the lung enters the field of view, obscuring usually your diaphragm to some effect, and sometimes the entire field of the solid organ. Some practical considerations for you when scanning patients with COVID-19. It goes without saying that proper cleaning is essential in this era, as it should be generally at any time, but particular attention to cleaning the entire machine with an antiviral wipe that is approved at your local institution. I think you should minimize the machine accessories. So if you've got little baskets that carry gel or carry extra cables or towels, I would suggest removing those so that you do not have to clean them and there's fewer fomites attached to the machine. We've seen many people sheathing their probes with the sterile sheath covers that are used for central venous access, just to keep the entire system relatively contactless with these patients. We've also seen examples of people covering the entire machine. You can consider using the coverings that are used for the ventilators to do this, or even a garbage bags. The see-through garbage bags have been used. Another practical thought is that if you have a hot zone and you're cohorting your patients, is that you designate a machine or multiple machines to stay in that zone so that they are not being moved around to different zones, and therefore mitigating the risk of some degree of nosocomial transmission. And how do you integrate your findings with respect to COVID? Well, if you're initially assessing a suspected COVID patient, perhaps in the emergency department or on the ward, I think you should consider the value of ultrasound over X-ray. Often these units are, for assessment, are quite overloaded with X-ray requests, and the cleaning obligations for the machine, the PPE consumption for the X-ray tech are non-trivial. And really, we know that ultrasound of the lung is at least as good as CT with respect to we know that lung ultrasound has similar diagnostic accuracy to CT, and we should put that to use. So for the patient who presents with dyspnea or fever, you may look for a lung ultrasound that shows an A-line predominance to reassure them, especially if they have other known pathologies that may cause dyspnea, such as asthma or COPD, that an A-line pattern would be strongly suggestive of that underlying process. The negative predictive value of an A-line pattern in the COVID era has not been determined. However, it's fair to say that an A-line pattern largely excludes an interstitial syndrome, and it would significantly alter my post-test probability in assessing these patients. As I've mentioned, if you can demonstrate a clear set of lungs in an objective fashion using an imaging device and can save those images, my feeling is that, especially during pandemic times, if your culture currently mandates radiography for these patients, now is the time to push through lung ultrasound as a similar, as an acceptable means of imaging. Trending the inpatients would be another application of integrating your findings. So I think, again, minimizing radiography by trending their findings on lung ultrasound, evaluating for the burden of B-lines and or the presence of consolidations. Of course, you're going to trend them primarily clinically based on their work of breathing, their oxygen requirements, as well as other features of multi-organ failure and inflammatory blood work. Assessing for consolidation, I think, is fairly important. It may help us determine patients who may benefit from lung recruitment, whether that's chest physio, whether that's intensive spirometry, or in the ICU setting for recruitability. And recruitability is a topic of great interest, so the idea of being on a ventilator and the idea that identifying lung that may be suitable for recruitment maneuvers with elevated PEEPs is of great interest in these patients because their lungs are otherwise quite compliant, and many are reporting using lower than normal PEEPs for these patients in light of that. And so there's a balance between obviously over-distending the lung with PEEP and also under-recruiting their lung and putting wind in their face while they fight off an otherwise aggressive pulmonary infection. And evaluating for recovery, and there's actually some interesting examples of this on social media of physicians scanning their own lungs as they recover from the virus, but ultimately we know that the progression to an A-line profile would be the clearest indicator of recovery from this ailment. And of course, you'd be quite wise to, while in the room scanning these patients, invoke the other modes of ultrasound that you're familiar with to take other clinical questions off the table, with particular interest in cardiac sonography for assessment of any ventricular dysfunction that is rare but quite severe in some of these patients, as well as examining the legs, for instance, for DVT, because hypercoagulability has been another issue. And certainly if you're suspecting a pulmonary embolism, it will be much easier to do a bedside DVT study to confirm the presence of clot than to risk transporting patients to the CT scanner for pulmonary angiography. So in conclusion, lung ultrasound is an extremely powerful bedside technique for imaging the lungs in the setting of a pulmonary pandemic. It provides a number of advantages over conventional imaging. It's faster than X-ray. It's more accurate than X-ray in trained hands. You can trend things without having to repeat those kind of studies. CT scanning of these patients seems unclear to me the value of that, especially if you have lung ultrasound. Also, the cleaning obligations of a CT scanner for COVID-positive patients are significant for healthcare systems. So I'd encourage you to consider embracing lung ultrasound if you haven't already. Hallmark findings include a patchy distribution of B lines throughout both lungs, so it may not be homogeneous across both hemithoraces. And of course, the irregular pleural line is not specific to COVID, but it certainly does point towards a more infectious etiology. But of note, irregular pleural lines may also be seen with other causes of pneumonia, with inflammatory lung diseases. So do not put everything on that, but be mindful that that is what we'll expect to see. And as I've mentioned, I think you should really combine this technique with your other efforts with POCUS, including your cardiac DVT studies, putting in your central lines, get them all done at the same time, and minimize the consumption of PPE and the ins and outs through the room. And there's a lot more to be learned as our case volumes increase, of course, and so our knowledge on this topic will be fluid, and we will update you as such concrete information becomes available. With that, I thank you.